here on this occasion. And I think it is not though almost the last but not the least. I think the topic, as you know, is translating guidelines to practice, choosing antihypertensives and lipid lowering in diabetes. I think this speaker is none other than the great orator, Dr. Tiny Nair, who is the head of and chief cardiologist of PRS Hospital, Trivandrum, presented papers organizing CMEs and delivered invited lectures at state, national and international levels, presented the first beta blockers in heart failure study in India 1994, principal investigator of several multinational clinical trials, several ongoing original publications, special interest in hypertension, heart failure, MI in the young, antithrombotics. So I think this is a very important session because deals with the cardiovascular, any drug, as we know in diabetes, needs a cardiovascular outcome study. So I think, and we know that now that the treatment of diabetes is not control of sugar, but control of the important risk factors of hypertension, diabetes, etc., lipid, dyslipidemia, and a comprehensive approach is needed. I think in the interest of time, I'll ask Dr. Tiny Nair to start his session.
Good evening, ladies and gentlemen. You know Professor Titus. Everybody knows that Professor Titus is one of the finest interventional cardiologists in India. But what many people don't know is that he is deeply and keenly connected with preventive cardiology. In fact, he, after his stint at Sri Chitra as the president head, he now is involved in the preventive clinic of cardiology clinic in the SUT hospital. One of the main components of atherosclerosis is the smooth muscle cell beyond the fat. Now, if you look at the smooth muscle cell under the electron microscope, it shows some kind of unusual vacuolations, what you see there, I've shown by the red arrows, very early in the process of atherosclerosis. And those ones are not simple, but pretty complex. And today we know that they are called caveoles. So very early in the process of atherosclerosis, you take a smooth muscle cell and put it under an electron microscope. You see the small vacuolar structures. They start from the cell membrane, start as a small invagination, go inside, and they are called caveolae. And do understand that they are almost similar, but not same as the lysosomes, which are shown side by side. Remember that name, caveolae. We need that as we proceed with the discussion. But we are clinicians, let us come to the clinical topic first. In the year 2010, the British Heart Foundation published this study in Lancet, which showed the connection between diabetes, blood sugar, blood pressure, and cholesterol. And this is a huge data set of 6.98 lakh population. Look at the data. On the x-axis, you see the cardiovascular events. And on the y-axis, you look at different parameters. For example, the first graph on the right shows the blood pressure. So the relation between blood pressure and cardiovascular event rate in a diabetic. And understand that the relation is pretty linear and strong. So as we bring down blood pressure, the cardiovascular event rate in a diabetic obviously comes down. Look at that lipid levels. Yes, again linear and strong. As we bring down cholesterol, LDL cholesterol, the cardiac event rate comes down. But what about blood sugar? The relation between blood sugar and cardiovascular events are not really very strong, non-linear and quite feeble. And that is why today when we talk about cardiovascular event rate reduction, apart from the A of diabetic control, we talk about B, blood pressure reduction, perhaps C, cholesterol reduction, and B and C are very, very important. That is what the topic is all about. Now, if we start with hypertension, if we talk about hypertension, there are a huge number of guidelines. We don't want to go through them. But if you look at those which are talking about diabetes with renal disease or diabetes without renal disease, you see the drug preference almost every guideline talks about either an ACE inhibitor or an ARB, meaning that there is a thrust on RAS inhibition. So the focus is on RAS inhibition. If you look at that 2015 ADA guideline, again very clearly says that for the diabetic with hypertension, we use either an ACE inhibitor or an ARB. In fact, the choice is open. You can either use an ACE inhibitor or an ARB and shift to the other if one is intolerant. So understand that we are focusing in the management of hypertension and diabetes on RAS inhibitors. Why so? We know that right at the center of the neurohormonal circus is angiotensin 2. And very early in diabetes, angiotensin 2 tends to go up. And we also know that angiotensin 2 is a very potent vasoconstrictor. Angiotensin 2 through aldosterone retains sodium, and that's why hypertension comes in, fine. But what we don't realize, what we often miss out is that angiotensin 2 also increases sympathetic drive. Angiotensin 2 also retains salt and water independent of aldosterone. Angiotensin 2 modulates ADH secretion. And that is why we talk about when we suppress angiotensin 2, either by an ACE inhibitor or an ARB, whatever, we give the patient a combination of an beta blocker, a vasodilator, a diuretic, and perhaps a vasopressin antagonist, all in one. And that is why today angiotensin inhibition has come in the forefront in the treatment of all kinds of hypertension associated with diabetes. But for the clinician, there is something else. The important thing is whatever drug I prescribe to the hypertensive, my hypertensive patient doesn't have a symptom. So once I give a drug, it is important that he continues it. And then only we get the benefit of the antihypertensive. Now, if we look at all the antihypertensive drugs, this study came in 2009 and looked at the network of the persistence of treatment. How long people persist with the treatment. The ARB with a 2.27 is on top. So if you start on a medication for your patient of diabetes with hypertension, the drug that the patient is most likely to continue is ARB. If the patient develops a cough or pedal edema or erectile dysfunction, bronchospasm, he might stop the drug and not come back to any one of us, which is very, very important. The second interesting point that came out, not really came out, which forms the background of the guidelines for recommendation of drugs in hypertension associated diabetes is this. Let's say I treat my patient with a drug for hypertension and it lowers the blood pressure by 4 millimeters, red drug. I say it's good. Now I give my patient a blue drug and that reduces blood pressure by 7 millimeters. So I say blue drug is better than red drug. Logical. But what we should realize that in the management of hypertension, the simple logic many often doesn't work. For example, at the end of the 24-hour time period, at the end of the day, my red drug still reduces blood pressure by 3 millimeters. And my blue drug reduces blood pressure again by 3 millimeters. So if you understand, the red drug has a trough-peak ratio of 3/4 into 100, meaning 75%, while my blue drug has a trough-peak ratio of only 45%. So as far as hypertension treatment is concerned, a red drug, which might be less potent but longer acting, is better for the management of hypertension because it's persistent, long duration, and probably would produce a better outcome, which is important. That's why when we choose a drug, for example, among ARBs, if we're choosing, we always tend to choose a drug which has a long half-life rather than one that is short-acting. What about combination? Today we know that we use a combination therapy right from the beginning, provided the blood pressure is very high, like the presenting blood pressure is 160 over 110, I would use a 2-drug combo. Point number 2, if a single drug fails to control blood pressure, obviously logic is use a second drug. And we know from the trials that if you look into the trials, the number of drugs used to optimally control hypertension mostly are more than 2.5. In fact, most people with significant hypertension would need more than one drug. And that in diabetes, if we are talking about a combination, the guidelines show that you can use obviously an ACE or an ARB plus either a CCB, calcium antagonist, or a diuretic. Now, trials like Accomplish has clearly shown that in the diabetic background, if you're using a combo, perhaps an ACE or an ARB with an CCB would be a better choice compared to an ACE ARB with a diuretic. But what is new is that people are talking about low dose of a drug that has less side effect. We also know that if we combine two low doses of two drugs, we have a more potent combination. So people have started thinking, why not start low dose combo very early in diabetes? It's not come into the guidelines, but it's significant discussions are going on. In fact, very many people who work with hypertension and diabetes are talking about why not try two low dose combo quite early. Now we shift gears and go from hypertension there and lipids. In fact, we don't have a lipid guideline in India, but me with about 12 of our colleagues, we spent many sleepless nights, many travels, and finally we came out with the consensus statement of management with dyslipidemia in Indian subject. We don't call it as a guideline, we call it as an consensus statement. But the point is, there was a lot of discussion, in fact, in the ACC, last ACC in March, that is Dr. Rajiv Gupta, perhaps the most published epidemiologist, cardiac epidemiologist in India from Jaipur. We actually did two sessions back to back. I did one and Dr. Rajiv Gupta did the second. But before we come to that, we have some data to show that why in lipid management today we're going away from goal. There's a huge database that came that showed that if we look into the lipid lowering and look at the huge data available with statins, we see that whatever be the level of starting a lipid level, people tend to benefit. In fact, the final take-home thing is, in type 2 diabetes, 1 millimole of reduction of LDL gives us a mortality benefit of 9%, a cardiovascular mortality benefit of 13%. Now, the most important crux of the whole thing is, this reduction is from any starting lipid level. So whatever be the starting lipid level, we benefit. So are we talking about any starting goal? No goal at all. And that is why today, if we look at the new guidelines of the ACC/AHA on lipid lowering, we're talking about 3 clinical scenarios where we have to start on statins, whatever be their lipid levels. Point number 1, atherosclerotic coronary vascular disease, ASCVD. Number 2, very high LDL. And number 3, our topic today is diabetes. So today, any diabetic has to be on statins. In fact, if you look into the new ADA guideline on cardiovascular risk management that came in 2015, it's very clear. Any person between the age of 40 and 75, diabetic, no associated risk factor, needs to have a moderate dose statin. Any person between the age of 40 and 75 with a cardiovascular risk factor or overt CVD needs a high dose statin. So moderate dose statin, high dose statin for every diabetic. More than 75 almost the same, but we should be a little careful about statin side effects. And what is a moderate dose statin? The moderate dose statin is a statin that reduces LDL from the baseline to about 30 to 50%. And we have 10 and 20 of atorvastatin and about 5 to 10 milligrams of rosuvastatin for that. While when we're talking about a high dose statin, high intensity statin, meaning that a statin that reduces LDL from the baseline by more than 50%, we have 40 to 80 milligrams of atorvastatin and 20 to 40 milligrams of rosuvastatin. Now, we come back to the first slide from where we started, the smooth muscle cell with a lot of caveoli there, what we call as caveoli, which looks like lysozyme, but they are different. Now, these caveoles are very complex structures, and even today we are not clear how they come, but we kind of know, this came in circulation a couple of months back, we kind of know how they start. It's a very complex pathway, but as a clinician, you and me, we need not go into it, but look at the starting point. The starting point is angiotensin II. So today we know that in the prevention and treatment of coronary or whatever atherosclerosis, inhibition of angiotensin II goes a very, very long way beyond hypertension. Point number 2, if you look at the terminal part of the whole circus, you see something called AKT. AKT is a serine protein that has been involved in the final common pathway of atherosclerosis. And it is said that this is one of the things that translate the manifestation of caveoli very early. How can we inhibit AKT? This is one of the papers that very clearly show that rosuvastatin tends to inhibit AKT. Not only rosuvastatin, statins. And that is why we understand today that inhibiting angiotensin II as a treatment of hypertension or inhibiting AKT by a statin would go a long way to treat atherosclerosis and cardiovascular event rate, which is the focus of every lipid-lowering and hypertension treatment in diabetes. So, ladies and gentlemen, where are we in conclusion? So, in conclusion, diabetes, RAS inhibition by ACE inhibitors or ARB forms the cornerstone of therapy in hypertension in diabetes. Low-dose combination of multiple drugs in hypertension might increase compliance and might actually return a lower cardiovascular event rate. Point number 3, statin benefit groups are in focus today instead of the numbers. So today we are looking at the groups which would benefit by statin treatment rather than looking at number of LDL. We do have numbers, but the focus is shifting from numbers to focus groups. And finally, benefit of RAS inhibition by ACE inhibitors or ARB and statins go far beyond lowering lipids or controlling blood pressure in type 2 diabetes. Thank you for your time and attention.
So thank you, Dr. Tiny, for your very, very crisp and very brief message. I think we would say I think the bottom line, I think, for hypertension is in this scenario of diabetes is the RAS inhibition, ACE, ARBs, and also, of course, statins. These are the bottom line. But then, of course, we have certain compelling indications, like patient with coronary artery disease and hypertension. Maybe I think they would also benefit certainly by the addition of beta blockers, or especially if they have some element of heart failure with hypertension, diabetes. Certainly they would benefit by the addition of beta blockers in that as a compelling indication. Besides, I think basically the recommendation is actually what he has said. What do you feel, Dr. Tiny, about the place of saroglitazar, patients with high triglycerides, particularly high triglycerides? What is the place of saroglitazar, or maybe the addition of ezetimibe in some cases? And I think they are all. I think they are also in the guidelines, but at a lower level, and also the use of fenofibrate, etc. Because it's a diabetic symposium, I think the background, the use of this alpha, PPR, alpha, gamma, that's also an option that's available. But primarily, I think, as you rightly said, I think it would be only statins and RAS blockade. I think let's have some comments from the audience or any queries. Please give a mic there. I think even in the place of high triglycerides, I think primarily you should, with dyslipidemia, you should primarily use a statin. And particularly, I think if the HDL is low and the triglyceride is high, maybe rosuvastatin may be a better statin of choice. And then, of course, with an optimum dose, you then reassess what is to be done to the triglyceride, etc. Yes, sir.
I find a large number of blood sugar raising agents like statins, of course, it's necessary, but beta blockers, why not choose carvedilol, which is a beneficial drug rather than metoprolol in higher number of patients? I was told it's a costly drug, now cheaper brands are available. Now the other one is frequent use of diuretics, both of which contribute to higher blood sugar levels. What about the cardiologist? Why are you using such a large number of hyperglycemic agents?
I think a very, very important question and a comment. I think it's very important that many of the therapeutic agents that we use daily, be it a diuretic, be it a beta blocker, be it a statin, today we know that they give rise to increased incidence of new onset diabetes. For example, statins, every statin increases new onset diabetes with a relative risk of 9%. But we know that the benefits of statins are so far more stronger than this new onset diabetes. And the new onset diabetes harm probably would be so low that we give statins. But certainly, sir, what you have said is important, that perhaps the new beta blockers, be it a highly selective beta blocker like a bisoprolol, nebivolol, or one with an alpha blocker like carvedilol, have less metabolic side effects like unlike metoprolol, and probably we should choose to use them. But in India, generally, carvedilol is still considered to be one of those beta blockers used for heart failure rather than in hypertension. I have yet to see a person with hypertension being put on carvedilol in India. One, because carvedilol sustained release is not very popular in India. And second thing, we are not used to it, but it's a good suggestion. We should try to avoid drugs, especially in diabetic, which presents the metabolic sugar control here. Any comments?
I entirely agree with you. I think as far as the role of diuretics with hypertension, I think certainly you could use, but then in hot weather you would find that there could be dehydration and electrolyte imbalance, lipid abnormalities, which may be probably less now with the availability of chlorthalidone. Small dose. So I generally reserve diuretic for the last because of these effects. Generally I would put the patients on the drugs already mentioned. But maybe in resistant hypertension, you can certainly use drugs like aldactone, spironolactone, etc. So I would keep that as the option at a lower level after trying these basic drugs that are available. But I think certainly it's an option for resistant hypertension, etc., where it's difficult to control the blood pressure.
Diabetic dyslipidemia has three components. One, the total cholesterol goes up. Second, the triglycerides again goes up with drastic reduction in high density lipoprotein. The LDL is not that important. There will be a marginal or modest elevation. Even if it is normal, it is supposed to be highly atherogenic. That is so the three components are hypertriglyceridemia with drastic reduction in HDL and total cholesterol going up. And here we have agents like fibrin and niacin and all that. But they are not supposed to be that effective. What is the present status management of diabetic dyslipidemia?
It's a very, very important question that, in diabetes, apart from the LDL being higher, we get a high TG and a significantly low HDL. Most of our, statins reduce the event rate, but statins generally tend to address more of LDL lowering rather than TG lowering and HDL elevation. Drugs like fibrates and niacin look good on paper, they reduce the TG, they raise the HDL, but unfortunately, none of these trials, whether we are looking into ACCORD or whatever meta-analysis, none of them has showed that either fibrate or niacin standalone has tended to reduce cardiovascular event rate. Okay, having said that, we did find that there is a small signal. For example, if you find a person with a TG by HDL ratio of more than 4.5, a triglyceride by HDL ratio more than 4.5, they tend to have more of small dense LDL. We say that, okay, your center may not be doing LDL particle size, your center may not have an ApoB, ApoA ratio to look into small dense LDL. But one simple rule of hand for checking out small dense LDL would be a TG HDL ratio. If you have a TG HDL ratio more than 4.5, perhaps addressing it is important. And that is a subgroup, even in ACCORD, if you look into that subgroup, they had a higher event rate, and with fibrate, their event rate did come down. So, despite our knowledge about triglyceride lowering and HDL elevating being so poor, we are today trying to get some of the subsets who would have a better outcome with fibrate. If the triglyceride levels are more than 500, obviously we need to address them to prevent pancreatitis. Okay, we have to put a fibrate or a niacin or whatever saroglitas are, see your choice. But to reduce cardiac event rate, I think none of these agents have really shown to be beneficial unless we are looking at a very, very small subset. Yes.
Those two studies, HPS Thrive and Aim High, where they used niacin, as you rightly said. I think they, in fact, were negative studies. So I think now they are not recommended. I think it's only statin and only statin. Yes. I think any other, it's a very important topic for a diabetic. So I think, yes. Yes, sir.
Hello. Good morning, sir. I am a pediatric surgeon in PRS hospital. My finding is that many cases of bad diabetic foot cases, you get along with hypertension, you will get a normal cholesterolemia or DLP, and mostly less than normal. What may be the reason for that? Many cases are recorded.
So the question is, he's a pediatric surgeon. He actually is a very efficient pediatric surgeon. It's a huge number of diabetic foot. So he generally always says that when he sees a bad foot, he sees that the lipids tend to be the normal and lower side. Is there an obvious reason that can be explained?
The lipids are lower, or is that lipids are lower, or the pulse volume is normal? What do you say?
Total normal DLP.
Pardon?
Normal dyslipidemia.
Normal?
No increase in
No?
LDL, HDL, or even TG. All becomes normal or below normal. Many cases we are recording.
No, I think we generally don't go by these values. No, I think we should, of course, do I didn't get your question, whether the pulse volume is less in those people, or what is the angle brachial index of those patients?
Angle brachial index is almost normal in many cases.
So that means there's no peripheral vascular disease if it is normal.
Maybe
If it is normal, there is no if it is 1 or above 1, it is normal. But if the vessels are calcific, then you can get a higher ABI of even 1.3, etc.
in that connection.
So I don't know whether it is just a non-ischemic ulcer or something, if the angle brachial index is normal. But generally we see that the aortoiliac disease actually is the major contributor. If there is a patient of diabetic or smoker with aortoiliac disease in any form, I think there's a very high risk of them having either a cardiovascular or a cerebrovascular disease. If 2 vessels are blocked in the leg, 1 in the brain, 2 in the heart, and 4 vessels in the peripheral vascular disease. That is the ratio. So peripheral vascular disease is there's a very high incidence of coronary and cerebral. So I think certainly they should be put on statins, because many of the surgeons insist on a coronary angiogram before these patients are taken up for a peripheral vascular surgery.
His question was that he finds these lipids normal in diabetics. That is what he was trying to mention. Second thing, he is not disputing this the ratio. Correct?
Yes.
By my experience is that we find that most of the patients, what conventionally described as high triglycerides is not seen at least in this part of Kerala. We find moderate elevation of LDL, and many of our patients, even frank diabetic status, dyslipidemia have nearly normal triglycerides. That is probably the Kerala pattern. Now, we treat all of them. For the answer to his question is, even moderate elevations of LDL, we treat them aggressively, vigorously, because we have proof that that LDL lowering is useful and effective. Now, triglycerides, unless they're very high, we don't try to treat because the result is poor. in the present scenario, there is no effective drug to treat triglycerides, moderate triglycerides levels.
See, I think,
third thing is to divide now triglyceride-rich lipoproteins and balance, rather than going in for HDL-LDL ratio. And that's a current knowledge.
Yeah, I think the peripheral vascular disease patients, I think the major risk factor is smoking. There, I think you do not find much of, you only find a low HDL, and you don't find, you may not find gross, different, very high values of LDL you may not get. Because the predominant risk factor for peripheral vascular disease of the type you said is actually smoking. There you generally get a low HDL. You will not in those cases get a high LDL. Those patients you may get, provided they also have associated coronary artery disease, etc. There you will get. So this is actually an indication for using a statin.
So
Any vascular disease.
Smoking itself raises
cardiac
lipids.
or
Smoking itself raises lipids. So
I think the point we are debating is the point which is very important. See, if we take a population of diabetics, one with a vascular disease and one who doesn't have vascular disease, and plot their LDL or your HDL or triglyceride, whatever it is, in a bell-shaped curve in a population, you find there is no difference.
Yes.
So we take a diabetic who is a vascular disease, no vascular disease. That is the reason why we are shifting today from the goals. We're not fighting about why 100 LDL, why 130 LDL, is HDL 25 important, is HDL 45. Everybody, diabetic vascular disease, benefit by a drug called statins. And because of this confusion, because of this fight that we are having, that's why we have chosen not to go for the goal, but give everybody the benefit of therapy.
So it is better that you start with statins even if the lipid profile is normal.
Absolutely, sir. Absolutely.
Thank you, sir.
Sir,
whenever there is vascular disease, you have to, they are beyond statins. Yes, sir.
Previously, we used to give ARBs to prevent endothelial dysfunction. But nephrologist now says a hike in serum creatinine due to the early starting of these ARBs or ACE inhibitor do more harm sometimes. So as a primary prevention nowadays, statins and aspirin maybe have definite role. But in events like ischemic events like CAD, CVR and all, and as a primary prevention, better not to start ARBs early because in many cases they found that serum creatinine is increased and very difficult to control later once it is on the upper side.
Slight rise of serum creatinine is known on initiation of treatment with either an ACE inhibitor or an ARB, but that doesn't prevent us from starting a RAS inhibitor in a person who actually needs it. And like you said, primary prevention today we don't give an RAS inhibitor, but I see in the future, in the next couple of years of guideline, you can always see that every type 2 diabetic would go home on a RAS inhibitor, no doubt about it. Right now if you say, unless there is hypertension, do we have data? Yes, we have data. If there is microalbuminuria, you give ACE ARB to go to macro. If we have macro to prevent ESRD, we give ACE or an ARB. And today the data is emerging that even in a non-albumuric, non-hypertensive diabetic, probably we would get an indication for an RAS inhibition.
So,
I think these diabetics, I think need to be, we don't wait for the creatinine to go. I think you have to look for the earliest evidence of endothelial dysfunction by looking for microalbuminuria. And if microalbuminuria is there, then I think that is consistently there. Then I think it is the earliest evidence of endothelial dysfunction. I think that is the time when you have to start them on ACE inhibitor or ARB. Not they have gone on to the next stage of macroalbuminuria or raising creatinine. But creatinine, some 25% of rise in creatinine, as he said, will occur when you start this drug. But then it will stabilize after about 1 or 2 weeks. So that has to be followed, and also check for the potassium level.
so can I make a comment, sir?
I think we'll have the last question.
This is regarding ACE inhibitor ARBs. We usually start now ARBs itself in young people, and even diabetics with severe renal failure also. It is expected that when you start ACE inhibitor or ARB, there is a definite rise in 10% rise. That means if a patient's creatinine is 1 milligram, it becomes 1.1. But from 1, if it increases 30%, that is 1 to 1.3, you have to be cautious. You have to tell the patient to monitor your potassium and creatinine, and then we stop. And there are certain situations you have to stop, like during surgery, when there is some sepsis, an acute situation, you will stop the ACE inhibitors or ARBs and restart later once the condition is stabilized. Thank you.
Absolutely.
So I think we have had a long session. I think we will conclude the session, and let me thank the organizers, myself and Dr. Tiny, for being here. Thank you so much. And the audience for the interaction.